Hello, doctor, and all my dear classmates. So today we will be discussing about the chronic kidney disease in dogs. Okay, these are the group members. I'm Lauli 194685.
I'm Rafi'a binti Ibrahim, 193106.
I'm Narhanisa binti Muhammad Shukri with metric number 193108.
I'm Abdurrahman
Are
Arabi.
Winton? Oh, okay. Sorry, Abdurrahman first.
Arab, go first.
Okay, I go. Okay, I'm Ara Winton, matrix number 192989.
And I'm Abdurrahman Arabi with matrix number 195079.
Okay, so for a bit of a background, first of all, we know that the signalement is that the patient is a 4-year-old male intact dog. And its history is that it's experiencing intermittent periods of weakness and lameness. And through physical exam, we detected mild dehydration, foul smelling breath, and teeth covered in tartar. So we go straight into the hemogram. As you can see here, for the reading of PCV, it is rather low. The MCV and MCHC are normal. Red blood cell count is low, and the retic is at a 13.1%. Okay, so as you can see here in a hemogram, there is normocytic normochromic anemia. And when we calculate the CRP by taking the reticulocyte percentage multiplied by the PCV over the normal PCV, we get 3.2. And by calculating the RPI, we get a 1.2%. And this is a slight anemia. And from the leukogram earlier, we also noticed that there is lymphopenia, which is a very typical stress leukogram that we see. And however, this is not a typical stress leukogram because there is no increase in mature segmented neutrophil. But this may be because the animal itself is naturally having a low resting neutrophil concentration. And then we move on to serum biochemistry. Okay, as you can see on the table, the BUN, creatinine, and phosphate are very high. So these three are actually the hallmark of decrease in glomerular filtration. Sodium and chloride levels are low normal, and potassium is at a high normal. This is a typical sign of kidney problem. Okay, then we shall move on to the next interpretation, which is the urinalysis. So there is, as you can see on the specific gravity, it is 1.008, which is within the isosthenic range. And the isosthenic range is 1.008 and to 1.012. When your urine is at this range, it means that there's a sign of a tubule problem. You're unable to concentrate your urine well, and that's why it's very dilute. So, and you can also see a small number of erythrocyte and leukocyte. Actually, this is normal. Perhaps there is some contamination during the collection of sample. You only take into account these WBC and RBC counts when they reach above 20. Yeah, that's it.
So I will be talking about the pathophysiology. In this part, we are just basically going to articulate whatever we interpreted with the possible pathology that we could think of. So firstly, what I think the possible damage would be in is the glomerulus. It's called glomerulus nephritis, which means there is a loss of function to the glomerulus and the tubules. Why do we say the glomerulus is damaged? As we can see that from the blood profile, the CKD levels are low, right? Is it low or high?
Creatinine kinase, is it?
a significant increase in blood urea nitrogen, creatinine, and phosphorus levels. These are three products that actually passively filters through the glomerulus. So if there's any problem to the glomerulus, they actually they don't get filtered through. So the increased levels of these three items on the blood parameters indicates a possible damage to the glomerulus. And when we looked at the urine specific gravity, the specific gravity is mainly determined by the concentrating ability of the tubules, and it's isostoneric, which means there is some damage to the tubules. So the conclusive idea that we could come for the pathology is that it originates from the glomerulonephritis. So when you have a decreased glomerular function, you don't have your waste products getting cleared off the body. So that results in blood urea nitrogen, high amounts of creatinine, and high amounts of phosphorus, which is really important because phosphorus, when it's an ion in the blood, it coagulates with the calcium and gets deposited. So you will have a mineralized tissues. So when you have a serum calcium level going down, one of the other functions of the kidney is to regulate the parathyroid hormone. So in a chronic ongoing kidney disease, you can see that there will be a further problem with the endocrine regulation, where you can see there is low levels of vitamin D3. And if the damage is not just limited to the glomerulonephritis structure, it's also suspected that in other damage to the tissue of kidneys, like the interstitial tissues, could possibly pose damage to the endocrine system related to blood production, which is the erythropoietin. If erythropoietin is not secreted well enough to regulate to produce more red blood cells, then we suspect that the anemia is because of the lack of erythropoietin production. So that's the pathophysiology mechanism that we can interpret from our findings.
So, okay, right. So based on the pathophysiology along with the clinical findings that we've already discussed before. So the possible differential diagnosis for the chronic kidney disease would be SLE, systemic lupus erythematosus, nephrogenic diabetes insipidus, and chronic glomerulonephritis. So as we can see, like based on the clinical sign, like for the bad breath, it can be caused by the formation of tartar from the teeth, which may cause from the bacteria build up on teeth. But it can also be from an ongoing medical problems inside the dog. So it's like based on the reading, so probably there are some kidney problems happening inside the animal. So apart from that, usually in chronic kidney disease, we can actually observe polyuria and polydipsia, but it is not being stated in the history. So so for diabetes insipidus, usually in the urinalysis, we can actually see like the specific gravity would be within isostoneric range or lower because of the kidney damage and failure of the tubules unable to concentrate in urine. Apart from that, we can also see high levels of glucose. And then next for SLE, usually in the biochemistry, we can actually observe the levels of albumin would be usually low, and this is probably due to the loss from the failure of glomerulus to function. And inside the and for the hemogram, we can usually see inflammatory leukogram. Usually, it's within normal high range because of the chronicity. And then the last one, which is the chronic glomerulonephritis, it's similar to SLE, where you can actually observe inflammatory leukogram, where there's going to be monocytosis and neutrophilia as well. There's a left shift of neutrophilia. It's we can based on the hemogram that we observed, there are much changes in the leucograms, and there's only like what was so let me see, where is it? Oh yes, so the only changes that can be observed in the leukogram would be the lymphocyte, lymphopenia. So apart from that, the levels of albumin in the urine will also be high. So because of the loss of the protein, so yeah, sorry. There would also be presence of protein in the urine because of the albumin due to the loss of the albumin. So yeah, that's all. Mm.
Okay, moving on to further diagnostic plans. There are three possible diagnostic methods that we can use. So for the first one, which is the ANA test. Moving on to the next slide. So the ANA test actually is an anti-nuclear antibody test. This test helps to evaluate the patient that suffers from autoimmune disorders, which affects the tissues and organs throughout the body. And this particular test can be diagnosed to diagnose patients with systemic lupus erythematosus, because this ANA test can be considered as the most sensitive serological test. And firstly, how it works is that anti-nuclear antibodies are a group of autoantibodies which are produced by the animal's immune system when it fails to adequately distinguish between self and non-self. So this ANA test, it helps to detect these autoantibodies in the blood. However, this test is not the most specific of tests. It can be positive in up to 20% of dogs with other infectious diseases, such as leishmaniasis. Aside from that, to confirm the diagnosis of SLE, a positive ANA test is needed, alongside other diagnostic results such as significant clinical signs and hemogram results. Moving on to the next test, which is urinary culture. Um, this urine culture is done to detect any infections present in the urinary tract. So when there is an infection, it can complicate the primary cause of the chronic renal failure. And when this test is done, a second test is usually conducted, which is called the sensitivity test. This test is used to determine the most effective antibiotic to use against the bacteria involved. Moving on to the last one, which is ultrasonography. We can also do an abdominal ultrasound to check for any abnormalities of the shape, size, and the placement of the kidneys. Aside from that, in order to diagnose chronic glomerulonephritis, we need to check the urinalysis results and also perform an ultrasound-guided kidney biopsy to further confirm the diagnosis. After sending the sample to the lab, we can observe the histopathology of the glomerulus to find out more about the cause and the type of inflammation. Some examples of lesions that can be seen in the chronic glomerulonephritis cases are fibrous scarring of the glomeruli, reduced number of glomeruli, high number of tubules, ischemic, undergo pressure atrophy, and are replaced by scar tissue. Besides that, tubules that remain connected to the glomeruli may become dilated and develop into epithelial hyperplasia or hypertrophy. So what I want to say is that for the first differential diagnosis, which is SLE, this disease can be ruled out because only one of the clinical signs is present, which is intermittent periods of weakness and lameness. Since this SLE is a fairly rare disorder, um, we have to we have to get a more significant signs such as a non-erosive polyarthritis, skin sores and blisters, proteinuria, decreased platelet and white blood cell count, and fluctuating fevers. So SLE can be ruled out because it lacks significant clinical signs. The next disease, which is nephrogenic diabetes insipidus. This disease can also be ruled out based on the clinical signs that the patient showed. Because this patient did not show any symptoms of polydipsia or polyuria, so we cannot make any further diagnostic plans. For the last disease, which is chronic glomerulonephritis, this disease can be a possible diagnosis because the patient's urine specific gravity is 1.008, which is in the isostenorate range and considered as highly diluted urine. This means that the damages to the nephrons are severe. And moreover, chronic glomerulonephritis can be considered as a precursor for chronic renal failure or end stage kidney. That's all from me.
So lastly, the treatment. First of all, we'd give osmotic diuretics to increase the concentration of urine, like mannitol or glycerin. Secondly, we provide an IV fluids to correct the electrolyte imbalance and provide a renal friendly diet. Uh, what I mean by renal friendly is a diet where there's decreased dietary protein, limited amount of phosphorus, and mildly restricted amounts of sodium, and presence of omega-3 fatty acids in the diet, and like a large amount of water in the diet. And lastly, uh, we'd give binders such as epactine in dogs to bind with the free phosphorus. Those are our references, and that's all from us.
Thank you.
Thank you.
Thank you.
Thank you.